Good afternoon, everybody, and welcome. It's the 9th of June, and this is the formal meeting of the Strategic Commissioning Committee in Lancashire and South Cumbria. As a number of members of the public have registered to observe our meeting this afternoon. Thank you for your interest in our work. You're very, very welcome to be here. Could I ask, please, that as we continue to operate in this Microsoft Teams environment, that to help me manage the meeting, if you could keep your microphones and cameras turned off, and respect that the chat column is part of the meeting and therefore for use by members of the committee or other participants in the meeting. I would appreciate that very much. Thank you. The Health and Care Act 2022 is on the statute book. This is the last time that we'll come together as the Strategic Commissioning Committee for Lancashire and South Cumbria. The 2012 Act, the glory days of world-class commissioning, sometimes it feels to me like it was only yesterday, but you all went through that, our 8 CCGs, through that process. I want to properly recognise and indeed pay tribute to the work that each of the 8 CCGs have done in Lancashire and South Cumbria. I joined this party relatively late in this whole period, but it's very clear to me that a real strength and asset in our system has been the way that the CCGs have worked in the interests of the populations and the communities that you all serve, but also the way in which you come together to work collectively across the whole of this patch. You've managed resources and advanced health and healthcare in each of your areas through very challenging times of austerity, through very challenging times of pandemic, and you've been central to the coming together of what have been the integrated care places. You had the foresight to come together at a relatively early stage as a joint committee of CCGs to work across the system. That developed into what we have now, the Strategic Commissioning Committee, which has been vital in managing this past period and in supporting the transition into the new ICB. You've held together your organisations. We're in touching distance of the closing line now. You've continued business as usual alongside all the work that's being done to support close down and transition. And I particularly, with both appreciation and admiration, thank the chairs of the CCGs, Richard and Peter, Samantha and Lindsay, Adam and Jeff, Graham and Roy, for the leadership you've shown through the totality of this period. With huge respect for the professionalism and commitment of Andrew and Dennis and Julie and Jerry and others who fulfil the roles as accountable officers, and their teams, your teams, some of whom have contributed in this committee, many of whom have contributed more broadly to the delivery of business as usual, as well as this very challenging process of transition and close down. And on behalf of the new ICB, the successor body in that sense, I thank you for making all of this much easier and much more effective than it otherwise could have been, and indeed that it is in some other places. But the most important thing, I think, is that the the legacy that we leave as the clinical commissioning groups in each of the 8 areas is that the most important legacy is that the things you've done to the benefit and advantage of the populations you serve and the communities that they're in will continue into the beyond the life of the CCG. I could draw examples out from each of the 8 of the fantastic things that have been done, continue to be done. The outstanding leadership that's been shown by clinicians and by others across the whole spectrum of the work. And I wanted to formally, on the record, give proper recognition and an appreciation of that. We're in a strong place for this transition, and the personal leadership that all the chairs, all the accountable officers, all the lay members, everybody in the governing bodies, everybody in the executive team has brought to this, has contributed to that, and I thank you very, very much indeed on behalf of the ICB and on behalf of the wider system in Lancashire and South Cumbria. Of apologies for today's meeting from Jane Scattergood, from Sarah Shepherd, from Sam Prophet, from Kevin McGee. None of these folks are voting members of the committee. I think we're all here, we're able to do the business that's in front of us today. I've not received any more or new declarations of interest relating to items on the agenda. Our minutes of the meeting that we had on the 12th of May. Are there any points anybody wishes to raise on the minutes? Any to raise? No, thank you. Can I propose that we adopt the minutes, please?
I'll formally second those, Chairman.
Thank you very much, Roy. Right. Andrew, there was one item there about the ratification, particular ratification of the agenda items 11 and 12 from the last meeting.
Yes, thank you, Chair. So there was a point recorded on the minutes last time when the meeting lost its quorum. A colleague had to leave and we were not quorate. And there were a couple of items of formal business relating to a medicines management policy and a commissioning policy, which were therefore not able to be decided upon. Wanted just to confirm in the paper you see on slide 13 that we did contact members of the committee by email seeking their approval and received that approval, but this paper today puts that on the formal record, and so I'd like to ask the committee to ratify the approval for those 2 policies considered at the last meeting. Thank you, Chair.
Thanks, Andrew. Very efficient. We can content to give the ratification sort, please.
Agreed.
Thank you very much. Done. Right, Kevin, over to you.
Thanks, David. Just thought I'd update you on a number of topical issues at the moment. Firstly, the ICB readiness to operate on the 1st of July. We've been subject to a sort of regional peer review, if you like, along with the two other ICBs in the Northwest. That came back very positive. Pretty much everything was green. The one area we still have some work to do is around emergency planning. It's a critical area for us. The real issue for us is, unlike the other 2 ICB areas, they had a regional arrangement with dedicated teams that are continuing. We had a distributed arrangement, and our lead is leaving, sadly. So we've got everything in place, and the region's happy with that. Arrangements will be green by the 1st of July. So that's the first thing. Second thing, staffing arrangements. We are moving through the organisation now. We've completed the structure for the top team. We're out to recruitment for 2 posts currently, and we're also out to recruitment for the place-based partnership directors of health and integration, they're called. We're about to go through a process with at-risk staff. We've had several meetings with at-risk staff looking at what that 3rd tier structure is We've discussed it with them. That's about to be published to all staff, and we'll go through that process. Any unfilled posts would then be advertised more widely in the system within Lancashire and South Cumbria. I guess the third thing is you're aware that we're doing a review of the place-based partnership numbers and boundaries. I'm doing quite a lot of work with Jane Scattergood at the moment, getting out and about. I've had 2 meetings this week already and a couple more to do yet as well. So that's in train. The other thing we will do for the first business meeting of the ICB, it'll be towards the end of July, is to do a stock take of what we're inheriting, the good, the bad and the ugly, if you like, just to be clear on what the risks are and what the opportunities are and what a realistic set of objectives should be for the first year of operation. The budget will get a particular focus as part of that. As you know from reports, it's going to be quite challenging. It's a standstill effectively. It will have some risk in it. We will need to introduce some, I think, system-wide controls and monitoring processes so that we keep on top of it and get as close as we can to a balanced outturn at the end of the year. And I guess it's always nice, isn't it, to end on some opportunities. I think it's quite exciting. There are we've got firm foundations to build on. We've got a number of opportunities that are either just starting or about to start. One is around a project on discharge flow and community support. What can we do with the social care support system to relieve the pressure on our hospitals in the short term? You know, we've got winter coming up. But also in the longer term to increase capacity in key areas so that we don't have around 500 people blocking beds in our system. Second is shared services, so that we have much more a sort of streamlined back office and supply chain for the whole system going forward. Third area is having a longer term approach to how we plan things as a system. So we're starting to develop some early work on a 10-year plan and vision and a 3-year budget system for the new system. And also the ICB will have some new powers about how it selects partners going forward. It doesn't have to go through the process the CCGs had to in terms of the competitive process, etc. We intend to take advantage of that. So we're doing some work about what longer term strategic partnerships might look like for the new system going forward. And the idea would be that we're not managing around the contract as much. We've got a longer term perspective. We don't have lots of resource tied up with bidding for contracts and contingencies if you lose one. So that sort of money can go directly into frontline service, and they're more flexible and longer term in perspective. So I hope that gives you a flavour of some of the things that are on the agenda at the moment, and I think it's exciting. Thanks, Chairman.
Thank you very much, Kevin. Any questions or points for Kevin, please? Okay, thank you. All very good. Andrew, do you want to take us into agenda item 6, please, around the ICB and the formalities of that?
Yes, I will. Thanks. And it picks up on Kevin's first point about the process that's being used to establish the Integrated Care Board. Picking up this paper on slide 15, it's here for information. Colleagues are aware that we've brought some of the important establishment actions through the committee at different stages. A paper really in 2 parts today. Part A, just confirming the final stages of work that have taken place on the ICB constitution. Again, CCG colleagues have been involved in different aspects of that as it's developed. That part of the paper confirms Kevin will be sending through a range of information as part of the readiness to operate process tomorrow. So we are right at the end of that timeline now, as both David, you said, and Kevin too. So that's the part A, just confirming those formal governance developments. And part B, again, just updating on the timeline for the appointment of partner members. to the ICB, again, an important stage in our process, and we are on track in relation to those important membership issues. I know Deb Atkinson has joined the meeting. When you get very succinct papers like this, it doesn't really show the level of activity and hard work that's gone into this. So I particularly wanted to pay tribute to Deb and to Vicky Ellaby, who have really coordinated this process for us. Happy to take any questions, but the paper is here for information today. Thank you.
Thank you, Andrew. Points, questions, observations? Deborah, anything you wish to add?
I think just to add that since the paper was written, the Constitution has now been approved and published. So that was published on the 1st of June. But other than that, no, nothing to add. And thank you, Andre, for your comments.
Well done, Deborah. Thank you. Okay. It's going very smoothly. CCG close down and transition. Dennis, are you kicking us off on this, please?
I will do. Thank you, Chair. Just before I go into the detail of the report, just to extend a thanks to you, David, for the introductory comments about the change we're going into and the kind words you said about CCGs and everything that's been done. I would echo that, but I think I do appreciate it. I'm sure all my colleagues do as well. Okay, we've actually got here, ladies and gentlemen. So when we first set out on this process, seems like a long time ago now, we set it out to be a due diligent technical process. You appointed me as your senior responsible officer. I appointed Helen to work with me as programme director, and what we assured colleagues we would do would be to set up the structure for effective close down and transfer. We're here now in June, only a matter of days really before we move into the new arena, a new era with the ICB. And I'm looking at 2.2.3 on the report, and just reflecting on where we've got to. And for the 9th of June, which is today, we've been through the transition board earlier on in the week. We explained what we'd done. We explained all the sort of due diligence steps that we were hoping to achieve by this point, and we've got there. So today, each CCG will be asked to sign off by their AOs, the transfer documents that will go to Kevin as Chief Executive of the ICB. We're all geared up now, ready to do that. And then moving on to formalities by 27th of June, you can see in your pack then what will be included in all that transfer documents. So in a second, I'm going to pass on to Helen, who can take you through the detail of the report. All I really wanted to do this afternoon, Chair, is to assure colleagues that what we said we were going to do, we have done it. But a great deal of gratitude and respect goes to the small army of people who've been behind the scenes at each of the CCGs to make sure that we've completely coordinated our efforts in this programme, and it's testament to them that they stuck with it, even though I'm sure some of the initial requests from me sounded a little bit Teutonic, but there was a good reason for that, because we are where we are. So with that, David, I'm going to pass on to Helen to take us through the detail, if that's okay.
Yes, thank you very much, Dennis. Helen, please.
Thank you, Dennis. If I might, Chair, I actually want to take you to the end of the paper that you've got in your packs. So moving down to the recommendations on 5. That doesn't mean I'm only going to talk for 2 minutes. I will take you back to section 4. When I first wrote this paper, we had proposed that we would bring through both the Transition Board and the Strategic Commissioning Committee the evidence and assurance that we've had to date in order for the AOs to sign off the due diligence template. We didn't have to do that because each of the AOs is authorised in their own right to sign off that they are satisfied with the due diligence of each of the statutory organisations. But because we established a governance process right at the start, which sought assurance from both Transition Board and Strategic Commissioning Committee that we were satisfied collectively of the process. We ideally wanted to bring it through here and then all of the AOs would sign off together. It's also was important because we're a level 2 system, and by a level 2 system that means we're multiple CCGs moving into one ICB that doesn't have any boundary changes. However, we've had to sort of diverge from that particular timeline because NHS England had set a requirement that we submitted those templates by the 1st of June. And I'm pleased to say that actually a day early on the 31st, we sent all of those templates in, both to Kevin as the incoming ICB Chief Executive and also via NHS England effectively to the regional director. So they have already been submitted. However, we felt it was really important that we still proceed through the Transition Board and the Strategic Commissioning Committee to close off the governance loop, to confirm the fact that we have had a due diligence process running right the way through this programme. If I could take you to section 2.4, which is on page 23. This is just really to spell out for you that process. Again, this is part of the legacy that we want to leave, so that as we wind down both Transition Board and Strategic Commissioning Committee, it is clear the process that we've been through. So, for example, first bullet point, we established that governance process and the leadership with Dennis as SRO and myself as Programme Director. In terms of our programme plan, it absolutely followed the mandated due diligence that was set for us nationally. The worst thing that you can do is sort of ignore that advice and actually develop your own thing, and then you find that you're told off because you haven't done it right. So we've absolutely stuck right the way through to the national programme, and whenever there have been updates to that due diligence, they have been incorporated within the programme plan. So I think that's served us really well. We've reviewed at various different stages the critical path, because obviously when we first embarked on this programme, the date for the new organisation to come into operation was the 1st of April, and then there was the change to July. So we reviewed the critical path at those various different stages. We've had a robust reporting process, which has come through both the Transition Board and Strategic Commissioning Committee, and I know that many of you have been completely impressed by the number of appendices that you've had to wade through as we've provided those reports. Fortunately, there are a few of those for you today. We've had a risk register that's run right the way through the programme. That is attached as one of the appendices, and I think we should just note that on there you have a number of risks, but all those that are shown on there as green have actually been closed. The only one that remains on there is the risk relating to workforce, and it needs to be reworded because obviously it talks about risk to CCGs, and we've only got 3 weeks to go. But it is a risk that will transfer into the ICB because there is obviously work that continues to need to be done on, for example, the financial aspects in terms of close down of Q1 and so on. But I know that my colleagues, Vicky, on the receiver side are already looking at that, so that will transfer along as a risk. But the most important thing that we've had running right throughout this programme, which has served us really well, is the work that our colleagues for Mersey Internal Audit have provided in providing assurance as opposed to reassurance through this programme. We've had regular scrutiny of both locally within CCGs, with Mersey Internal Audit attending those CCG meetings where we've been planning for the close down. And one of the appendices that we've also attached for you at Appendix 4 is the evidence spot checks that Mersey Internal Audit have been conducting. So rather than you just me just saying to you, trust me, it's done, we've had Mersey Internal Audit looking at the evidence folders that have been provided against each line of the due diligence, so that that's there for both future reference and also to enable us to say to the AOs, we are comfortable with you signing off that the due diligence has been completed. We've also attached a couple of the briefings that Mersey Internal Audit have provided to us as a collective system with their recommendations around the programme and enhanced governance. And it's been really important that throughout all of this, that we've not just reported to the Transition Board and the Strategic Commissioning Committee, but that we've also reported to our own individual CCG audit committees and to our governing bodies. Because while there is a delegated responsibility to the Strategic Commissioning Committee, we have to keep reminding ourselves that it's the CCGs that are the statutory bodies. So we've ensured that that has run throughout the programme. We've worked closely with our colleagues on the receiver side. I've used often for you my house moving analogy, that CCGs are packing up the boxes in the individual houses and we're moving to this great big mansion, but actually it's the same individuals that are going to be unpacking the boxes. And I've heard Kevin talk about the foundations have been laid, but we've still some building to do. But what's really going to help is that a lot of the individuals will still be here and unpacking those boxes as we move forward. And so it's been really important that we've worked with people like Vicky and Carl and others at the receiver end as senders, and I think that again will serve as well as we transition. There are a number of things that we've still to do, so it doesn't end with the AO templates being submitted. We are doing a number of things to, again, assist as we move forward. One of those is the development, and it's referenced there as the final bullet point under that particular item. We're developing handover packs. So each of the CCGs will produce a handover pack. It will all be to the same index, so it will make it easier for incoming executives to look at their particular area of expertise. So, for example, quality will be one of them. So each CCG will produce a handover pack that will be a guide to everything you need to know about the position CCGs were in at the point at which we hand over. That will include things like our final governing body assurance frameworks, our risk registers and so on, as well as the detail around the quality governance work that we've done, handover statements from our primary care commissioning committees and so on. So that will all be in the handover packs. We will also be working on what's the to-do list after the 1st of July, because there will still be things for CCGs to do. I've mentioned one of them, which is around closure of the financial accounts for Q1. But hot off the press, we are just clarifying the detail around an annual reporting requirement that we may well be asked to do for Q1, and also the holding of AGMs. So we need to clarify how we're going to do that with the Integrated Care Board. David, I can see your face in terms of perhaps questioning that, but there is some guidance that says, sorry.
No, I'm not questioning it at all.
I'm sorry.
I'm sorry about my face. It's the one I was born with. I can't do much about it.
Okay, I've just seen this morning. I'm kind of staggered by the ask, but we need to do some work on clarifying that one. We're also going to be identifying, we're obviously working on the interim clinical leadership model, but we want to be clear that that may not cover everything that our clinical leaders currently do. So we need to identify any potential gaps so that we don't just stumble on them as we move forward. We've included also, we've been doing some what we've called operational snag lists, where we're just basically identifying things, just trying to be helpful, that we're identifying as closed down leads, that we're flagging to the ICB to say, have you thought of this? Have you thought of this? That's not pretending, you know, incoming execs don't know what to do, but it's just as we think of things, and emergency planning was one of those very things that we said we need to be clear on as we move forward. I would just like to finish, if I may, David, with a thank you from me as programme director. It wouldn't have been possible without the huge cooperation I've had from my executive colleagues. And if something gives us tremendous hope for the future, it's the collaboration that we've seen across close down from all of the CCGs and the individual governance teams within those CCGs. And if there was a plea, I think it would be that we recognise the talent of those individuals who have stayed behind, in a sense, to do close down rather than going on secondment to do the more sexy work around establishment. And as we move forward into the new structure, we really need to recognise that talent that I think has been very evident. So thank you on my behalf as programme director. Thank you.
Very well done, Helen. It's good. You should and will be able to write a book on all of this, and it's magnificent work. To Graham, please.
Yeah, first of all, David, I think if you echo the praise the work done on this area, it's absolutely essential and very detailed. So I'm really grateful for Helen and her team and everybody else who's done this work. One area I'd like to just hear a bit more about is the primary care commissioning committees, which of course are being, well, if it will come to an end on the 30th of June. And we are a little concerned in Pennine and elsewhere, I think, that there are so many small decisions that are made every month at primary care commissioning committees around practice mergers, practice changes, a whole range of issues. And I'd like some assurance about the way they'll be dealt with under the new arrangements. I understand there'll be one committee for the ICB, fine, but how that will deal with the hundreds and hundreds of issues that come up linked to each of our practices. And I just want to hear a bit more about that to make sure nothing falls between the gaps when we move into the new system on the 1st of July. Thank you.
Thanks, Graham. Helen, do you want to come back to you on this, please?
I'm going to say my response is going to have to be that's not my area of expertise, Graham. I'm afraid Peter Tinson has done considerable amount of work in terms of the plan for primary care and the new primary care commissioning committees. The bit that we've done from the close down perspective that we were asked to do was to pull together a list and a handover document from all of our local primary care commissioning committees, identifying those issues that we've dealt with recently and those issues that may emerge still further. I don't know whether there are colleagues on the call. I don't think Peter's on the call in terms of describing further, but Andrew's waving at me, so he can probably pick that one up.
Well, just building on your point, Helen, Graham, Peter has done quite a lot of development work on this. He introduced that to the transition board earlier in the week, and I'm sure he'd be happy to talk you through it. Effectively, my understanding is that there will be a group that will look at some of those day-to-day transactional issues that you refer to, as well as a group that will look at some of the more transformational aspects of the agenda, and that will build on a number of the ways of working that we've had, particularly in the last couple of years. I know Peter Gregory's here, so he might wish to add, but that question is being addressed, certainly.
Thanks, Andrew. Andrew, your hand was up anyway. Is there anything else you want to add while you're holding the mic?
Well, you weren't the only person that was feeling surprised at the potential for annual general meetings, David. I wonder whether we could just ask Helen to liaise with Kevin on that, because that's quite a novel request. I don't think any of us had heard that before. So I just wonder we do need to have an approach to that. Thank you.
Can I come back on that one, Andrew? So it's based on some slides that have been issued today, and so I am going to query that. It does talk about where your annual reports have been approved before the end of June. You could hold a sort of a rapid annual general meeting, which I don't think any of us are in the position to do. The other suggestion is that it could be done under the guise of the ICB board in Q2, which I think is going to be the far more sensible approach. But it's just sort of come a bit left field today, Andrew, and I just kind of need to clarify exactly what the ask is, and then I will liaise and we can agree the process.
Thanks, Helen. To Dennis, please.
Yeah, I'll just quickly respond to that latter point. I think it's a really pragmatic piece of advice, Helen. As you know, propose that's exactly what we do around that. Just be really practical around the art of the possible, and not just put unnecessary bureaucracy in place, regardless of who's asking for it. Just come back to Graham's point around the primary care committees. I think it's another really well made point, Graham. As part of the due diligence, we've also put in place a repository of sort of work in progress issues, and the primary care committees, as you quite rightly say, will have work in progress issues. So any particular area will be working through various conundrums, like it might be a practice who wants to extend the building and wants some capital decisions made on that are not going to be concluded by the end of the month. So all of those are captured and will transfer into the new arrangement to be continued. So I think it's important that we don't sort of lose memory of some of these issues, otherwise we'll be unwinding a lot of good work, and actually on the opposite side of that, winding up a lot of people who expect us or expect whoever it is to pick this up to continue with the knowledge of how to proceed with it. But big mistake, just let that sort of fall between the two stools.
Yes, yeah, thanks Dennis, agree completely. And to Peter, please.
Yeah, thank you. Just to reassure Graham in relation to the point about primary care, yeah, Andrew's absolutely right. There are two groups in place. There's a contracting group and a transformational group, both titled Primary Integrated Neighbourhood Community Care groups. Terms of reference have been agreed for both, and that's the formal arrangements in place. Informally, I think it's important to recognise that, of course, the teams associated with each of the CCG areas around primary care have already started to meet at Leyland, in Chorley House in Leyland, to build up those relationships, and the team's actually broadening as well. So confident with that, all that organisational memory is carrying over into the new arrangements, and will capture any potential issues that fall through the gaps.
Thank you, Peter. Got Jeff, please.
Thank you, Chair. All this detail and technical stuff is fabulous, and I'm just in awe and gratitude to Helen and everybody else who's done it all. And it's not really a comment any of that. That's just great and needed and well done. My comments really about, I hate the passing of CCGs as much as I like the future, and it shouldn't pass. Certainly, there's a view in Morecambe Bay, it shouldn't pass without noting the successes of the CCG, like you indicated at the beginning, David. And you know, there's something about all this work is necessary for the process, but there's something about recording and celebrating the success of the CCGs in a more public-facing way, I think, which this meeting particularly won't serve, I don't think. But you know, if I just think about Morecambe Bay, you'll all have had successes in your individual CCGs, and I think about Morecambe Bay, and we've had our population health work with Andy Knox, we've had our development of integrated care communities in neighbourhoods, the work around digital, the clinical leadership work has really transformed the clinical leadership in our area. You know, and indeed the development of Bay Health and Care Partners, our partnership, it's been fantastic. So there's been some real successes, and often the successes don't get remembered or celebrated, and it's always what you haven't done or what you haven't succeeded on. But I think a lot of the successes are down to people in this room or from the past who should be thanked and celebrated. And I just, we'll certainly be trying to record that in Morecambe Bay for posterity. And I think I would suggest all CCGs do the same.
Yeah, absolutely. Jeff, couldn't agree more. And Paul, please.
Yeah, it was just on the points that Helen made around the annual general meeting. There is a slight technical difficulty with this one. So the external auditors need to sign off the accounts for the 3 months and the annual report, which obviously then goes to the annual general meeting. However, they may not be able to do that until next year, until May, June next year. So it raises a technical issue. But even if we can find a streamlined process, you know, is it valid in terms of that final, kind of reporting of the results for the final 3 months of the CCG? So I'm sure everyone in the country has got the same issue. I think most auditors that I've spoken to won't be ready to do it until next year, given they've got capacity issues with local authority audits. So it does raise some more issues, unfortunately. But I think, you know, I would echo what Dennis was saying. If we can get a streamlined way of doing it, then that would be great. It's just whether we can tick those kind of statutory boxes in terms of what we need to do.
I'm sure we'll find a line of best fit through this. Back to Helen, please.
Yeah, I was just thinking, so that relates to the 22-23 Q1, doesn't it, Paul? But I think what we can do is sign off the 21-22 under an ICB item in Q2, I think, is what we'd be aiming to do, and then we can sort the first quarter of 22-23 out in a different way, can't we? I think, but yeah, I think we can find a way through it.
Yeah, it's just that the first three months may not be signed off until the following year. Yeah. Okay.
Fantastic. And Roy?
Thanks, Chair. It would be remiss of me as the chair of the transition board not to ensure that the vote of thanks goes to both Dennis and to Helen for the work that they've done in terms of leadership and tremendous amount of work. Helen's mentioned the work in the background of the CCGs and the staff, and they've been doing that, of course, with business as usual as well. So that work is, you know, tremendous amount of work they've gone on in CCGs, but we mustn't forget the work that Helen and Dennis have both led to this conclusion. And I think that effort is recognised by everyone on today's committee. I always liked Helen's analogy of the house moving, as she used that on several occasions during the transition board, and I'm not sure about the terminology of a mansion, Chairman, more of a two-storey 70s built brick building, office building, I think. So I thank them both for that and appreciate the work that's gone on. And as I say, to reach this position is a great effort. Thank you, Chairman.
Thank you, Roy. I mean, just before we confirm the paper, which is essentially signing off the template letter that the AOs will consider outside of this meeting, does anybody on the committee have any concerns about the assurance issues? This is the time to say it if there's something that you're concerned about that we haven't picked up at all in the process. It's remarkable. I mean, to extend the analogy, there's always one or two things that get broken in the removal crate. But is there anybody that needs to raise anything? Okay, that's fantastic, Helen and Dennis and colleagues. Remarkable piece of work and well done. So, Helen, is what happens next now that the letters for the AOs on the back of the discussion here now we will.
So as I was saying, because we'd had to change the timeline slightly, those have already gone. They went in on the 31st of May. Because,
sorry, I'd misunderstood that. Sorry. Yeah,
so they were needed by they needed to be in the centre by the 1st of June. So they've already been received by Kevin and by NHS England. That's why I said at the beginning I've had to change the ask in the paper really. So they have all been submitted. I've had nothing back from, and Jane's on the call, I've had nothing back from NHS England to say that there was anything untoward. I had submitted these papers for the Strategic Commissioning Committee alongside as evidence of what we'd done in order to enable AOs to sign that. So they have actually already been submitted.
Okay, thank you. Well done, everybody. Jane, Cass, if you're there, is there anything that you want to say by way of conclusion?
Thanks, David. So I think just to reiterate the recognition of the amount of work and the organisation that has gone around this, it's certainly given the regional team the assurance and reassurance that things have progressed really well. Helen, we did receive those. Thank you very much for everything that you sent through, and acknowledgement will be sent back to yourself in the next day or so. But nothing further to add from myself, David. No concerns or queries as we stand here at the moment.
Thank you, Jane. Right. So we've a small number of items of business as usual to consider in this final meeting. The next agenda item is about the all-age system strategies for autism, mental health and learning disability. And I think I'm right on time if Paul Heggett is here, please.
Afternoon, Chair.
Hi, Paul. Welcome. Over to you.
Thank you very much. So within the pack, we've circulated some slides in a paper form that provide people with an update. So I'm not proposing to share my screen. I'm just proposing to talk to that paper quite quickly, and then if there's any questions from anybody, happy to discuss. So members of the committee will recall, hopefully, that Alex Heritage attended this meeting to inform you all of the development of 3 all-age strategies. That's mental health, learning disability and autism strategies. And the aim of that work was to co-create an approach across Lancashire and South Cumbria, which set out our system-wide ambitions and vision for service users and carers to create some strategic alignment. The purpose of today is to come and close that circle and to provide yourselves with assurance that we've all but completed that process. We have some final drafts of some strategies, 3 strategies that have been developed with a real emphasis on engagement and deep engagement with our service users and communities, and also our colleagues who work across the system, broad and range. So this paper that is in the pack outlines the wealth of people who've been engaged in this. We've had over 250 people who at various points have been involved in the development of this, and that comes from a broad group of people. It's not just health, local authorities, both public health and social care, but we've also had housing colleagues, we've had probation, we've had people from prison services involved in this. So we've had a real broad range of people who talk to us about actually how the system works in terms of that. But we've also had our usual MDT approach with our nurses, clinicians and operational staff also involved. Most importantly, this process has been absolutely embedded with people with lived experience, and we've used our voluntary sector colleagues and advocacy services to support us to do that really well. We've managed to achieve 50 respondents to a survey, and that doesn't sound like many, but actually the amount of work that has gone into to identify those people, to work with them, to develop and to complete the questionnaires was actually considerable from our colleagues at People First. So a lot of congratulations really must go to them for the work that they did. And we've also developed 7 case studies. We've developed an editorial group for this, so the final version of this has been not done in a dark room, but actually we've had a lot of people involved, from clinical ops, local authority, commissioners, people with lived experience again have all formed an editorial group to come up with the final version, and they've given up some time to do a page turn, which has been very much appreciated. Then it's worth remembering there's been no intention with this strategy to dictate any individual organisation strategy. This is a system level strategy, and we're confident that this has achieved that high level ambition that we had at the start, and has engaged that broad range of sectors that were originally requested to make sure we're involved in this process. Genuine deep engagement, as I mentioned earlier, has come with some responsibilities on the back of this. So actually the people who we've engaged in this are now really, really keen to be involved in the delivery phase, and they're almost talking about this as a bit of a social movement, that we've got a group of people now who feel connected to a piece of work and it feels different. We've had some really good testimonies from people that this doesn't just feel like a strategy, it feels like a bit of a movement towards how we change and how we work differently. So just to conclude, this process has been overseen by the System Transition Board, and Isla Wilson, who is the chair of that board, has developed a letter that will go out with the strategies. The System Transition Board have also offered for briefings, information to be provided to other trust boards, the health and wellbeing boards, etc., in order for people to ensure that there's a really good understanding across the board of how that will work. So the request in this was to note the considerable progress that we've made with developing the strategies, but to also request that we are in a position to present to the ICB the strategies in their final form, and to offer to anybody who wants us to communicate or to attend or to participate in any conversations around the strategies, to know that there's an open offer for the Transformation Unit or Alex Heritage to be involved.
Thank you very much, Paul. This is again another piece of fantastic work. Andrew.
It is, David, and it's a really positive piece to bring to the last meeting, I think. Thank you, Paul. Really clear presentation for this. I think what is different about this is the fact that we've developed them as an integrated care system, because I think there was a recognition that historically for these areas of service, or for people in our communities who live with these sorts of issues, there'd been a tendency towards individual organisations taking their own strategic approach, and that might have aligned, but in many ways it didn't always align. And so the opportunity that we were exploring here was to see whether we could create an aligned approach across a system. And as Paul, you've said, it doesn't dictate to individual organisations, but it brings an opportunity to check whether or not an action or a priority does align to the sorts of things that have come out of this process. I think what we're particularly keen on the SCC doing today is commending this to the ICB, because obviously that becomes the successor body. I think we're very conscious when we've been doing this work that we're trying to develop a model of provider collaboration in mental health, learning disability and autism, and that includes NHS providers, but it also includes a range of voluntary and other providers, and that's quite an important distinction. Paul, I wondered if you might just add a little bit from the engagement with those people with a lived experience, because I think what has struck me particularly has been they weren't asking for the most ambitious or the boldest things to be available. They wanted some of the basic service coordination and integration arrangements to be ready and available for people. And I think that's quite striking, actually. So really, really happy that this work has got to this stage. I hope members will feel that they're able to commend this. And obviously, to David and Kevin, there's an approach with ICB colleagues about how this is then received in the new organisation. Thank you.
Yeah, thanks, Andrew. And to Debbie, please.
Thanks, Chair. I echoed the comments. I think it's a great piece of work, and thanks to Paul and colleagues for bringing it together and giving us a really pithy update. Really welcome the strengthening of the approach to involve and engaging the public in the strategy's development, and really pleased to see the range of activities and innovative approaches that have been used to really meaningfully engage the public, particularly seldom heard groups. I've got a couple of questions and then a friendly challenge, if that's okay. So a couple of questions really around assurance, and I most certainly do commend the work. It's just some finer points I just welcome a bit more information around. So I'm really pleased to see that two of the key ambitions around autism and learning disabilities recognise the need for people to have access to a good education. So I know that schools and FE colleges make a really critical and valuable contribution to the life chances, health and happiness of people who are autistic, have mental health challenges or a learning disability. I'm just wondering if we've been able to engage schools and colleges in the development of the strategies at all, or as well as we'd hope, and if that's something, if not, that we could maybe strengthen. And then I'm just looking ahead to the launch of the strategies in September. There's a range of continued challenges around delivery and outcomes in this area that will be improved by this work. And I'm wondering if we're able to use any of that rich feedback at the moment to get those improvements happening ahead of September. And then my cheeky challenge, my friendly challenge, is just around the language. So I think it's right to be really, really ambitious, because we want the best outcomes, don't we, and the best for our system. And I just reflected on some of the ambitions. They talk about a better understanding and a good education. Don't we want a great education, and is a better understanding enough of an improvement? So there's just something really, I think, as an outsider, when I've looked at it afresh, to say, are we being as ambitious around the language as we could be? So just welcome your views on that.
Yeah, no, really good point. So first one was around schools, and yes, we have by no means been into a huge percentage of schools, but we have engaged people directly from education. A few colleges have been involved with this process, and it's real testament to the NHS Transformation Unit who've delivered on this for us. We've commissioned them to do this work, and they've been into a number of colleges and educational settings to have conversations. There is more to do in that space, without doubt, but I think what we've got is at least we've touched into that to get some thoughts and feelings around it. But yeah, I take that. I take that point on, that there's more to do around that as we certainly as we roll this process out. I think that the information that we've gained should be used now. I think September, the strategies are in my inbox in final draft. It will be good to think about how we can accelerate getting the strategies out. So that will be something that certainly I can go and talk to Alex Heritage about, how we speed that up. Alex is obviously the SRO for the work, so it will be good to speed that up, because it's been a long process, but a worthwhile and deeply engaged process. So it has taken time, but it's been worth it in the end for some of the stuff we've found. Finally, just on your point around language, Andrew touched on it actually, that quite a lot of the service users who we've spoken to and engaged were quite happy with better. they were just quite happy with some improvements being made. They weren't critical because they understand the challenges and the fact that it's multi-agency, but some of them were coming from quite a low bar, and actually the language was considered that we weren't going to go and tell them it was going to be the most outstanding service they're ever going to have in the next 5 years. It was actually quite considered that a step forward would be endorsed by those people, and that they were happy and comfortable in that space. Happy to take the challenge back, and I think a group of people would take that back, but it wasn't that we weren't ambitious in how we presented our ideas. It was that they reined us back a little bit. Some of the people we were involved with actually challenged and said that in 5 years it might be a stretch to tell us that it's going to be outstanding, when actually we're coming from some of their experiences were disjointed, they weren't seamless, there was a difficulty in accessing services, so they were happy with the terminology used. But again, take it on and we can have conversations in the implementation plans or delivery plans around these. That it might be that we increase our ambition through that.
Thanks, Paul.
Lindsay, then Jeff, please.
Thank you, David, and thank you, Paul, for the presentation. I think really helpful, really good to see that wide engagement. It's really heartening to see, and really like the key ambitions and how simply they are presented. I think that for me is really good. I just wanted to ask around the timeline, and I think you just said it yourself around accelerating that opportunity to get these strategies out. For me, it feels like there's a huge opportunity around the actual operationalization of these strategies and what we're going to do, and you know, the time frame for that. And I guess for me, it would just be a bit of a challenge around that. As a clinician, you know, I think when I looked at the autism strategy, you know, number 2 on there is, you know, the timely process for assessment and diagnosis. You know, Paul, I think when we look at our current timeframes across our system, you know, we're really not offering a good service. I don't think, and I think it would be really nice to sort of really challenge ourselves about how quickly we can start to turn around some of those things, and how quickly we can start to really enact them to make some changes where we know there are particular areas that with a bit of focus we could potentially start to turn around, and I guess it's the prioritisation of some of those key areas that you've got within the strategy. So I guess it's just a bit of a timeline challenge, really, Paul.
I take that on completely, and I think given the condition they're in, the work we've done, I would absolutely endorse accelerating the release of them, and then the development of delivery plans on the back of that, because we do have the system transformation board, but also the subsidiary groups underneath that could take on some of that. So there's one for learning disability, there's one for autism, there's one for mental health. So the delivery plans could be driven through that mechanism. So I will speak to Alex as soon as he gets back from leave and make it clear that overriding feedback here is let's get on with it now.
Yeah, absolutely. Into Jeff, please.
Thank you, Chair. Thanks, Paul. I'm going to say something, and my GP colleagues may correct me, so and that's fine. But this is just my view of the world. I mean, I'm very keen to see autism and LD getting up the priority list. It's long overdue, and my question is really how this sits with your partners and what the thinking is there, because it reminds me of where we were with palliative care about 20 years ago. And there's been a massive investment in time and education and training and focus in palliative care in general practice over that time. And I'm looking at this and thinking, how well prepared and how is primary care, and how much have you done thinking about how primary care supports this agenda, because you can't do it on your own. And yeah, I think I as a GP feel not as well prepared around this agenda as I do around palliative care, for instance. So I'm just thinking that as this gets implemented, we need a parallel programme around that. And Peter and Lindsay, you may have thoughts on that, or other GPs, but it's just my concern that we don't operate in isolation, but we have an integrated approach going forward.
Thank you, Jeff. Thank you. Debbie, back to you. Sorry, Debbie, did you want to come back?
Oh, no, that's great. I think the point about the challenge is right, isn't it? And I think that what I would say I completely understand perhaps service users have said to us that a bit better would be amazing, so let's aim for that. But I think what we're about is saying let's give you amazing, and if we don't actually aim for that pitch, we can have improvement targets that are realistic about being on a journey. But I think it's about that ambition and that aspiration, and I challenge us all, because we do want the best. We want to be outstanding. We want to be trailblazing, because if we're not actually aiming for that, then we're not ever going to be able to sort of achieve the heights that we could do. Thanks. Thank you,
Debbie. Right, so we were asked to commend the paper onto the ICB. I very much look forward to coming back to there, Paul, taking on board the points that have been made today and thinking about how we can accelerate, Lindsay's point in particular, how we can accelerate and get on with this now. So well done to you and the team. And you have the full support of this committee now in moving forward in the way that you describe.
Thank you very much, Chair. Thank you, colleagues. I will inform Alex as soon as he gets back, and we'll get on cracking with a new process and new time frame. Thank you very much.
Thank you. Right, medicines management. Brent, if you're there, please.
Yeah, thank you, Chair. As you pointed out, it's the first of my two items, which are standing agenda items. The first relates to the outputs of the Lancashire and South Cumbria Medicines Management Group. So just one output for this meeting, thanks, Chair, which is an additional hormone replacement therapy agent. So we're not expecting it to have a significant cost pressure. We're making it available to try and widen access and give more options. So really just if any of the committee have any queries, or if you're happy to ratify the recommendation.
Thank you. Good process, Brent, which always relied on here. We can tend to ratify the recommendation, please. Thank you. Right, Brent.
Thank you. And then the second item relates to the outputs of the Commissioning Policy Development and Implementation Group. Again, just one policy today. This is an abdominal hernia surgery policy. It's a policy that was already in place in Greater Preston, Chorley, South Ribble. So that's been reviewed and then adopted on a Lancashire and South Cumbria footprint. Some changes in there from the clinical engagement process, and again, just whether the committee are happy to ratify that policy as written.
Be content. I can only see 9 of you on my screen. If anybody who isn't content, please make themselves known. We're content. Thank you. Well done, Brent.
Perfect. Thank you, Chair.
Roger, I think the framing for the quality and performance report in this is, here's the ongoing biggest risk that we need to make sure we keep an eye on as we transition into the ICB, please.
Absolutely. Thank you, Chair. I'll take the paper as read and I'll pick out some of the highlights. Just recognising the period's got continued pressures within the whole of the system. The report also this month separates out a few areas of performance, focusing on children and young people, and we're working with Children and Young People board members to develop a more comprehensive dashboard. With regards to urgent care against the 4 hours national standard, Lancashire and South Cumbria achieved 74.8% in April. Time to initial assessment shows a continued good performance for Morecambe Bay, and the longest mean waits being at LTH and BTH, with both of these trusts having the most challenged 12-hour plus waits, with a sharp increase in ELHT at the start of May. Length of stay can be an indicator of flow, and with increasing numbers of over 21-day length of stay in ELHT and BTH, with the other two trusts remaining relatively stable. For children and young people, the report looks at daily attendances and admissions to see if there are any noticeable increases, but figures remain relatively stable. Section 3.6.3 shows differential admission rates by CCG population and a pre-COVID comparison. With regards to cancer, the volume of referrals does remain high and pressures remain within the system. Performance in 4.4 does show a little bit more green than previously reported, which is encouraging, although we recognise there's much more to be done in this area. Pressures from increasing referrals impacts on the ability to reduce the backlog. In regards to diagnostics, the numbers on the waiting list continues to increase and performance against the 6-week target has worsened. LTH remaining the most challenged against the 6-week target and Morecambe Bay maintaining its strong position. The endoscopy waiting list has doubled during the pandemic, and half of which is sat at TLHT. The non-endoscopy diagnostic waiting list has increased again, with only BTH reducing its list. With regards to elective care, appointments remain higher than pre-COVID levels for general practice, albeit this is a fairly crude measure of capacity. Face-to-face appointments had a sharp rise in March. Demand management and advice and guidance increased in each of the last 3 months, which is a positive step. Activity recovery levels for the year were 90% for admitted and 101% for outpatients, and the elective recovery trend is upwards in the last quarter, with March's figure closer to pre-pandemic levels. A snapshot of recovery in April was 95% admitted and 95% non-admitted. Of note, the size of the CCG waiting list continues to grow. There was a sharp increase in March, and that was reported submission issues now being resolved, particularly with the private sector. And that also impacted on the numbers of over 52-week waiters that we have. So the waiting list now stands at 174,000. The 18-week target was at 64.2%. And we have 8,500 people waiting over 52 weeks at the end of March, 78% of which are at our 4 main providers, meaning 22% are outside the 4. There were 689 over 104-week waiters at the end of March, which was a reduction of 258 on the previous period. The waiting list for children and young people has also identified at least 7,780 children waiting for treatments, of which 153 were waiting over 52 weeks and 14 over 104 weeks. And at that point, Chair, I'll hand over to Catherine.
Thank you, and I'll just pull committee to some main issues. So we can just see on item 7, in terms of the COVID figures, we'll obviously be watching these as we step forward. There is now the warning, obviously, that with the reduction in the need for PCR testing, some of this becomes really defunct in terms of how accurate that is. And we do expect that this is indicative, and we do have a greater proportion of undetected infections in the community. We can see the weekly case rate for the 60+ in the northwest, and again that figure is falling month on month, but as we've mentioned before, it does seem to relate to testing. We can see from outbreaks we are seeing a significant reduction all across in relation to outbreaks. We will be watching this as we step into the ICB world, and obviously all the infection prevention and control will be maintained, and that joint working will continue. Across regulated care, really good news in terms of that lack of outbreaks and a lack of infections. And we are noting that actually when people are becoming unwell in the care homes, that they are quite mild, so they're not converting to those hospital admissions, which again is very good news. Just in relation to the COVID and the spring booster, to date, the Northwest regional position is 77.6% uptake, and the Lancashire and South Cumbria is 80.5%. So that is an excellent uptake. We do know that in the autumn, there will be a 15-week campaign, which will be very much like phase 1 in terms of the cohorts that will be invited. That will include our vulnerable groups and our elderly cohort, but also health and social care staff will be included in that. We are working some of those plans up now, and we are aligning some of those plans with the flu campaign, which has now been published. And it just needs to be noted that the 50+ free vaccination for flu isn't part of the campaign that will happen this autumn. Just in relation to other circulating infections that we have at the moment, you'll be aware that monkeypox is now a notifiable disease. And as of the 7th of June, the UK Health Security Agenda had detected 321 cases of monkeypox. 305 of those were in England, 11 in Scotland, 2 in Northern Ireland and 3 in Wales. Our understanding is there are 11 cases in the northwest of England, but none actually at this point in time that we're aware of in Lancashire and South Cumbria. Our infection prevention teams are working with our health protection agencies to be aware of that, and comms have gone out to all general practices in relation to notification of that disease as that circulates. So we are just watching that, obviously, as we step forward. If we go to item 8 and the safeguarding update, you can see there under 8.2 in relation to Marek, which we have brought previously, that has been refreshed in relation to Blackburn with Darwin and Blackpool, and those models have been evaluated and implemented. There are positive outcomes being identified with those changes, and that is focusing those plans and deploying some of those required milestones. So that is an improvement that will continue to be watched as we step forward. And obviously any changes around boundaries will obviously be picked up through that safeguarding agenda. Workforce is an issue, and one that is replicated across many of our services. So again, we're working across Lancashire and South Cumbria to ensure that gaps are covered, and teams are working across. So we have a number of practitioners that work part-time who are willing to take on extra hours. And we're also looking to see how we can bring the wider workforce in relation to the teams in acute and mental health services in as well to support across community. That will be something that absolutely is a focus and will link to the ICS workforce groups going forward. COPDOLs, which we have brought before, you will see that there is still a backlog in some of that, and some of that remains at the courts, but that issue will be carried forward. We're looking at some of the current areas for focus in relation to violence reduction, breaking the cycle of domestic abuse, and some of that statutory activity. So all of that will clearly sit under Sarah O'Brien as the chief nurse, and those plans are very much in place to step forward from the 30th of June into the 1st of July. And all of that statute has been aligned and is being fully supported. IPA and continuing healthcare, all the data is here under section 9. This will clearly be a high priority stepping into the ICB. All the CCGs who currently hold that statutory function are aligning those figures, working very much with our CSU colleagues across all of that in terms of discharge to assess fast tracks. I'm not going to talk all through those. As you're all aware, there are a lot of those targets that are off track, and we're working collectively across to ensure that that service does improve dramatically, and we can move the workforce into the places where it's most needed to ensure that those reviews are happening in a timely manner so that people get the right package in the right place. So that work is underway and has been for a period of time. All of the detail is underneath that, and Sarah O'Brien has put a task and finish group together, which will happen very, very quickly. I think the first meeting is in the first week of July to look at these key points and see what needs to happen in the here and now. Item 10, which is mental health and key areas of risk. Iact is obviously an area which we've reported on a number of times. We have seen that remain an issue across both our area and nationally, and there are groups in place. This will continue in terms of those recovery plans and working with the providers jointly to ensure that we can improve on that output and those benefits for people who need that. The same with the out of area placements. We are still seeing a number of those out of area placements, and we're not seeing that reduction. And we are off target in relation to the 0 target for 22-23. That ambition won't be achieved as we stand at this point in time. And again, there is work going on to look at that, and you'll all be aware that the capital bids have submitted to try and support that. Physical health checks, the data is outlined there. That will continue as we step through into the ICB, as will the support and provision for children and young people. And again, you're aware from previous reports around the activity in paediatric wards, the emergency department and services providing eating disorders to our younger cohorts. So that again will be an area of focus as we go forward. Learning disabilities, which is item 11, you can see from the inpatient metrics, you can see the variance against the trajectory was at -5 in terms of the adult inpatients. That is an improvement when you look at that on the month-on-month, but you can see on some of those figures that they haven't all improved. So again, this will go forward, and that weekly discharge facilitation meeting, which is multi-agency, which is having an impact, will continue. Those are the key points that we'll raise, and going forward we will be looking at doing the reporting differently with some dashboards on the top, and clearly we'll continue to work very closely with performance, but the focus will be very much on that so what question in relation to quality, and we'll pick up on workforce effectiveness, etc. So those conversations are currently happening and being mapped as we speak. Thank you, Chair.
Thank you, Catherine. Thank you, Roger. So as we've reflected in previous meetings, this set of metrics and the narratives with them reflect unprecedented pressures on the system over the past 2 years, and in my view, remarkable response from primary care, from secondary care, from community and mental health services that we've been able to provide. But the challenges are very, very significant as we try to get towards achieving the standards that it's our duty to deliver to. Roger, you put, and I ask this because there's a critical target date coming up in terms of the 104-week waiters. Are we going to achieve there'll be no 2-year waiters by July?
Chair, I think it's fair to say that's going to be a significant challenge. The trust that's most under pressure is LTH. That it's reliant on workforce and it's subject to a few individual specialties. At the moment, there's identified a number of risk patients. I'm not sure if it's published the figure yet, but I think it was the 8th of June figures, so yesterday's figures, it was under 100, and that's a mix of admitted and non-admitted. And obviously the risk with the non-admitted patients is even if we can get those dated, there is a potential for those to convert. So the numbers have come down significantly, and there's been a massive amount of work done, not only by LTH, but the system, particularly with mutual aid support. So the numbers have improved, but there is still significant risk there, Chair.
Does that mean that those less than 100 people haven't got a date?
Yes. they're being micromanaged by the organisation. The organisation is I think it's got a daily sit rep report on its 104-week position. But yeah, there is still a little bit more work to do before we can have that assurance.
Gemma?
Yeah, it was just to support what Roger was saying, David, that they are micromanaging it. They've got weekly meetings with all the COOs trying to look at any mutual aid that's possible across the system. And they are still saying that they will be, but whether or not that's going to happen, but that they are hopeful.
Did we open the mutual aid conversations as early as we should have done?
Well, it's been part, I mean, certainly when I was chairing the weekly COOs meeting, 104-week waits was always on the agenda. So working at that system level was absolutely on the cards. Whether we reacted as quickly as we needed to, I can't say that, David. They would have an opinion on that. But we've certainly been monitoring it for a long time and very conscious of what the implications are.
Thank you. Any other points, please? There's so much in this report. Lindsay, please.
Thanks, David. I just wanted to say thank you to Roger and Catherine for pulling out some of the children and young people metrics within the report. I know it's something that I think I feel particularly strongly about, that we need to really recognise that cohort of people in our population. They make up a huge amount of our population, but also are those that sometimes are at the most risk of harm where we don't intervene early enough. So I'm really grateful to both of them for the work they've started on that, and hopefully we can really continue to elucidate that information. I think that'd be really helpful. And just picking up on, you know, David, your comment around the 104-week waits, you know, we've got children, young people in that list. When you look there, I think it's 6.3.19, you know, that there are a significant number, a small number, but a significant number of children who've been waiting more than 52 weeks and 104 weeks for their treatment. And I think that's something that really is significant, and we do need to sort of pull out. So thank you to Roger and Catherine for the work they've started on that, and hopefully we can continue to build on it. Thank you.
Thanks, Lindsay. Anyone else? Okay, well, a lot of these issues clearly fall into the in tray for the new organisation, as you say, Catherine. There's discussions and work going on about how we present and manage going forward. We've got the CCG Transition Board papers to note. Anything you want to highlight, Andrew, on that note?
No, thank you, David.
I've not been notified of any items of any other business. Right, Roy.
David, thank you. I think you started this meeting with a huge number of thanks to people, which was absolutely right and proper thing to do. And I recall when we established the joint committee of CCGs and then subsequently moved to the strategic commissioning committee. And we said that we would have an innovative approach and ambition. And we would have a potential and an opportunity to do things differently and work in a collective, with a collective sense of responsibility. I think, Chairman, you've indicated that at the beginning of the meeting, but I just wanted to say that I believe those things have been achieved by this committee, and that has no doubt been helped enormously by your chairmanship, and I would ask the committee, therefore, to join with me to record formally a vote of thanks to you, Chairman, for realising that ambition, that sense of ambition. And I think, members, you would all agree with me in those comments. Thank you. Thank you, Chair.
Thank you very much, Roy. Right, we're done. Thanks again to everybody. All the contributions have made this out. I mean, it's important business. We've had statutory business to discharge. That's all been done effectively. The spirit in which it's been done is fantastic, and you know, people have contributed positively. There's been occasional moments of fun plenty of enjoyment in the way that business gets done, and that makes life easier for all of us. So thank you all very much indeed, and see you soon.
Thank you, David. Thanks, everyone.
Bye bye.
Thank you.